So thank you so much for having me. Before we get to the slides, I just wanted to start with a conversation, and I wanted to start with a patient case. And this is a real case. So a 56-year-old woman presented to the emergency department saying that she felt very anxious. The emergency medicine physician who saw her diagnosed her with anxiety, gave her a short prescription for benzos, and discharged her home to follow up with her primary care physician. Less than 48 hours after that, the same patient returned to the emergency department saying she still felt very anxious. The second EM doc who saw her saw the first note and noted the benzo prescription and expressed concerns about possible drug-seeking behavior. He discharged her to follow up with psychiatry. Less than 24 hours after that, the patient returned to the emergency department for a third visit, saying she still felt so anxious. My resident picked up the chart, briefly scanned the first two EM notes, and confidently told me this should be a quick disposition. So as he went to go see the patient, I decided to take the time to review her electronic medical record. And I did note the two recent emergency department visits. But what I also noted was prior to this week, she had never been a frequent utilizer of the medical care system. She saw her primary care physician for her annual well checks. She was up to date on her mammogram and colonoscopy, and her cholesterol levels were really good. There was no prior mention of any mental health concerns anywhere in her chart. So why would somebody who appeared to be the picture of health suddenly present to the emergency department 3 times in a few days saying that she felt very anxious? And the answer to that why was missing in the first 2 EM notes. So when my resident ambled back to me and said, well, it looks like she's having a panic attack, I asked, why? And he answered something along the lines of, which led to a really important teachable moment where we discussed the heuristics of premature closure, anchoring, and diagnostic momentum. Then I went to go see the patient, and I sat down with so much compassion and empathy to create this psychologically safe space so she would feel comfortable disclosing to me whatever terrible trauma had happened that changed her life so dramatically in the last few days. And I'm so glad I did, because it turns out I was completely wrong. She said that her life was going great. Her kids were thriving in school. She had just had a big promotion and pay raise at work. And she and her husband celebrated her accomplishment with a romantic trip to Fiji. And they had just flown home from that vacation. Spoiler alert, psychiatry is not the service I ultimately consulted for this patient. Her CT showed a massive saddle embolus with significant right heart strain. Now I ask you, if you were dying of a PE, would you also feel anxious? Now, the data points for this patient were the same all 3 visits. At all 3 visits, she was the same person, age, weight, race, sex, gender expression, religion. None of those data points changed for the 3 visits. Additionally, at all 3 visits, she was tachycardic, tachypnic, diaphoretic, and felt a sense of impending doom. What was different between the 3 visits was the lens through which the doctors viewed those data points and how they assigned the importance in that list. If you are somebody who has some level of internal bias that women are more dramatic and tend to be more prone to panic, when you see a chief complaint of I feel anxious, your lens will focus more highly on that data point, and you are more likely to diagnose the patient with anxiety, particularly if they are of a particular racial, ethnic, or religious background that carries that additional stereotype burden. If you have some level of internal bias, that if somebody has a prior prescription for a controlled substance and come back for a return visit, that is the data point your lens focuses on, and you are more likely to see that as drug-seeking behavior, then that is where your lens will focus, and that is what you will see. So same data points, different lens, three very different outcomes from those 3 visits. Now, the truth is, we all have a lens. It's part of who we are as humans. Now, how is that lens forged? Well, it's part of our upbringing. So I ask you, where were you raised? Was your community mostly homogenous, or was it culturally and ethnically diverse? Did you move around a lot or travel a lot, or did you stay primarily in a smaller geographic region? What books did you read growing up? Who were the authors? Who were the characters, and what did they look like? How did they interact with each other, and how did they interact with other characters that weren't like them? What TV shows and movies did you watch growing up? What did the characters look like, and how did they interact with each other? What foods did you eat? What did your friends and family look like? And how did they explicitly and implicitly show you how they interact with people who look and think differently than they do? What was the slant of your local news? They all have a slant. So what messages did you receive along the way about who you are, what your place was in the world, and what other people were and how to interact with them? It's a series of messages that help forge our lens, which begins in childhood. It's not anything that you had necessarily direct control over. And once that lens is forged, even to any extent, that is the way that you will view the rest of the world. So for example, let's talk about dogs. So if you grew up in a neighborhood where the only dog that you ever saw was this bitey, snarly, barky, vicious dog, guard dog down the street that was attached to the end of a thick chain around its neck, and you were pretty sure if that thing ever got loose, you were gonna die. Or, so your lens in that perspective, of course, would be that dogs are bad, dogs are scary, dogs are to be avoided. But if you grew up in a household where waggy, fluffy, cuddly, loving dogs were a part of your family, your lens would be that dogs are wonderful and they're friends and they're fun. So imagine those 2 different people, 2 different circumstances, then in the future come across a snarling, vicious, scary dog. The first one with the lens, dogs are bad, that will just immediately confirm everything they ever knew about dogs. Lens won't change, dogs are bad. Okay, but the person who grew up with the dogs are good lens is most likely to see that dog as a one-off exception, different than what they're used to seeing, and it kind of doesn't count. Now, imagine again that you're that person that grew up with the dogs are scary lens, and you're in the park, and a golden retriever puppy breaks away from its owner, bounds across the grass at you, and jumps on your foot and gives your ankle a little puppy nibble. Okay, you have 3 choices because you have this dogs are bad lens and how you are going to think about this and respond to it. Number 1, you can stick very firmly and rigidly to the dogs are bad lens and see this little fluffy guy as a future killer. Number 2, you could say, okay, well, this dog isn't so bad, but most dogs are bad. So this is a one-off exception and I can ignore it and not change my lens. Thirdly, you can look at this dog and see it is disconfirming to your previous experiences, and perhaps your lens was too rigid and the scope too narrow when you learned about dogs, and you can take it as an opportunity for growth. It is our lens that helps us focus where we are looking when we're looking at the data points in front of us. And that's what happened with our PE patient. It was the lens, the focus on the list of data points that led to the different outcome. I'm going to show you a little picture here. In the pink owl t-shirt with the open book is my daughter, Reagan. And sitting next to her is her best friend, Kylie, from 4-year-old preschool. They did everything together. Now, one day, Reagan and Kylie conspired to wear the exact same sparkly t-shirt to school. they were going to trick their teacher, Mrs. Van, and switch name tags and switch chairs. Now, to be clear, neither Reagan nor Kylie have any visual or cognitive deficits. They are both well aware that they have different color skin, different style hair, and at least a 3-inch height difference between the two of them. But the data point they counted as most important in their identity swap was the sparkly t-shirt. Now, Mrs. Van was such a good sport about it and played along, and a lot of giggling ensued. And it just goes to show that it's the lens that we focus, where we focus our lens, that makes all the difference. Now, you may have heard people say things like the phrase, "Oh, well, I'm colorblind. I don't see color." Only is that completely asinine. It's physiologically impossible. You see color. And even if you are among the 1 to 5% of the population that is literally medically colorblind, you can still see some level of color. You can also see shades. You can see hair, height, age, clothing, weight, gender identity, wheelchairs. Pretending that you can't see all these things is completely absurd. When people proudly assert that they are colorblind and don't see differences, what that implies is if they are proud that they don't see a difference, that implies it is a bad thing if they did see the difference. And then that implies that it's bad to have differences. But why would it be bad to have differences? I mean, that's completely ridiculous to not see differences. What if I were to send these two animals to your living room? And you tell me, "Oh, I don't see carnivores, I just see felines. They're all just cats to me." Well, my friend, 50-50 chance you're gonna end up as a snack. We do see color. We do see differences, and that's okay. There is nothing wrong with that. That is not the problem. So what is the problem is pretending that we don't see it. So now we're starting to get a level of understanding around the fact that we do have a lens and we can change the way we see things, and that we're not colorblind. We do see differences. One's a tiger, one's a kitten. Those things are super obvious to us. So let's stop pretending that doesn't exist. Now, as healing professionals, though, we like to believe that we make choices based on the science and the data, because we're scientists, right? And especially as healing professionals, we're more compassionate than the average person. So are we exempt from these things, seeing differences? Well, let's see what the data shows. So long bone fractures. I think we can all agree that a snapped femur sounds super painful. Scientists don't always agree on topics across spectrum, but I think this is one that there is very little controversy. I have a couple small bone fractures here in my hand that I'm rehabilitating right now, and that hurts a lot. I can't imagine how painful it would be to have a broken femur. So that's a good area of study. So looking at this study here, I'd like to highlight the important part. Hispanic patients with isolated long bone fractures were twice as likely to not receive any pain medication. Any? Yes, any. For something we all just agreed is a super painful condition. So let's keep going. So again, long bone fractures. Multivariate analysis that controlled for potential confounders. African-American ethnicity continued to be an independent predictor of no analgesic therapy. And I assure you, this literature is extensive, particularly in the area of pain, where they use things like long bone fracture and kidney stone that we all generally agree are painful conditions. Well, what about heart? What about the acute coronary syndrome? Heart disease is the #1 killer of men and women, so that will be equal, right? The heart doesn't really care what your skin color is, does it? Well, it turns out African Americans are less likely to be admitted. If they were admitted, less likely to a coronary unit and less likely to receive coronary artery bypass grafts, with all other things being equal. 600,000 patients in this registry, and it's shown consistency with other studies noting disparate care based on gender and ethnicity. Again, so cancer screenings, again, rates are particularly low. Nonverbal communication, people are more likely to have misunderstandings, and even something like gout, that people are less likely to receive treatment and monitoring. And the importance of monitoring with gout is that portends higher risk for coronary artery and peripheral vascular disease if somebody does have gout. So that level of monitoring is extremely, extremely important. So as much as we love to believe that we are all completely exempt from those things, we're not, and it still happens, and these disparities exist. None of these are old studies. These are robust studies. There were so many studies that even if I clicked through them through my entire talk for 30 minutes, we still couldn't get through all of them. So the truth is, those things exist and they are real. We are not colorblind. We do have a lens. Okay, does that mean we're all just doomed? Are things just gonna suck and people are gonna get unequal care until the end of time? Well, fortunately, no. The good news is there are things that we can do about it. So I'm going to talk about 4 ways that you can increase the flexibility and scope of your lens regardless of where you started. If former KKK members can become passionate advocates for diversity, it just goes to show that anyone can come from any lens and continue to improve. And even if we think that our lens is very fair and very diverse-minded, the data shows that there is still unequal care. So we all still have room for improvement. So here are 4 things that we can realistically do to help with our lens. Number 1, audit yourself. On a shift during treatment, after you come up with a diagnostic and treatment plan for a patient, just every once in a while, audit yourself and say, would I do that exact same thing if that patient were me? If they looked just like me? If they were my mom or my brother or my sister? And occasionally, you may find that you may alter your care a little bit when you give yourself that internal audit. And that's okay, that's a good thing. We already know that there's disparities in care. What we can do and accept is that we have an opportunity to do differently. So just give yourself that little internal audit. Now, again, that lens we have can be rigid or flexible, and we want to continue the flexibility of that. So number 2, the thing you can do is expose yourself. Now, not in the kind of way that's going to get you arrested, of course, but you can expose yourself to a wide variety of people and experiences. Read books by authors who don't look like you, who have characters that you wouldn't typically interact with. Watch movies and television shows with people who don't look exactly like you and have very different background experiences. Try new foods. And as the world continues to safely open up from the pandemic, travel. They say that travel is the great equalizer. And the more people travel to regions and cultures that are different than their own in terms of religion, dress, climate, culture, absolutely everything, they are substantially less likely to express explicit and implicit bias. So getting out into the world makes a huge difference. Number 3, ask. Don't assume that you understand the context of what your patient is going through. Now, if the first 2 EM docs had asked the PE patient, they also would have found out that information, that her life was going great. And why would somebody whose life is going so great be having a panic attack? And it became very obvious very quickly that it was a medical, not mental issue. But what if they asked the patient her context, and it turns out that she had lost her job and lost her home, and she and her young children were living in the back of a car in a very unsafe neighborhood? Now that's a completely different situation, and certainly something we don't treat with catheter-directed thrombolytics. We need to ask what is going on in the broader context of the lives of our patients to find out what's really going on. Now, they've done so many studies about how quickly doctors interrupt their patients, and that is within about 12 to 18 seconds. which is not enough time for somebody to explain the context of their life. So taking the time to sit and ask is something that can make all the difference and save a life. And then lastly, do not assume that just because you are speaking the same language, that you are speaking the same cultural reference and vernacular. Well, I was giving a grand rounds recently, and I made a completely amazing reference to an episode of Saved by the Bell where Jesse Spano got addicted to caffeine pills for like 22 minutes. And it fell completely flat. It turns out that kids these days don't grow up watching Saved by the Bell. So they have no idea the cultural reference I'm talking about, even though I'm clearly speaking English and you can understand all the words I just said. It's that reference point. And that's part of where our lens comes in. Those reference points are from our books and TV shows and experiences as a child. So don't assume that somebody has the same reference points you do. Now, vernacular, again, can lead to a lot of trouble. My husband, Ryan, is an amazing emergency medicine physician. And early in his career, he went and saw a patient and asked, "What brings you in today?" And the patient said, "I fell out." And Ryan said, "Fell out of what?" And the patient said, "No, I fell out." So he was trying to regroup and say, "Okay, what were you in when you fell out?" And the patient said, "Oh, I was in the passenger seat of a car." And so Ryan asked, "Well, how fast were you going?" And the patient said 70 to 80 miles an hour. And now Ryan, growing increasingly concerned, is now palpating the patient's C-spine and asking a bunch of questions about trauma. And the patient, growing increasingly annoyed, wondering why the doctor was touching their neck, did not understand what was happening. They were both native English speakers and they had both heard the term fell and out before. But what Ryan had never heard is the term fall out as a vernacular for pass out or syncope. And the patient, since they had heard that vernacular their whole life, assumed that everybody used those words and didn't understand why somebody wouldn't understand that. So they were speaking the same language, but completely not meeting in the middle. Fortunately, they were able to figure out each other's situations pretty quickly, had a good sense of humor about the whole thing, and the patient got an appropriate syncopal workup. But all of those things can make a huge difference. So quick review before we go on to the workplace. When we're dealing with our patients, take the time to audit yourself. When you want to increase the flexibility and scope of your lens, expose yourself. When you want to understand the context of your patient's life, ask. And don't assume you are speaking the same cultural reference and vernacular, even if you're speaking the same language. Then you can add in the whole additional stress of even if you don't speak the same language. Now, so far in diversity, I've been using things like race, ethnicity, color, and gender as placeholders for the bigger context of diversity. But as we all well know, there's way more to diversity than that. So we have things like personality, culture, health, ability, access to resources, work experiences, political views, philosophical beliefs, spiritual beliefs, age, attractiveness, learning style, communication style, introversion, extroversion amount, where are they at on that scale? Their geography of origin, their adversity history, marital status, family status, economic background, cultural background. I mean, the list goes on and on. And there's an absurd amount of studies showing the importance of diversity in the workplace. So, I mean, the data is crystal clear. You have better income, better outcomes, better innovation, all those things. However, I don't know about you guys, but I am not responsible, nor do I get a say in who we hire. So that's a whole separate talk that I hope that our leadership who are responsible for those things listen to, because the importance of diversity is amazingly crystal clear. But diversity isn't the only thing. Diversity is a numbers game, right? Diversity is being invited to the party. Inclusion is being asked to dance. So even in cultures and workplaces where there is some level of diversity, if those who are of the diverse thought, political view, gender, age, or any of those things is not included, we lose the benefit of their diversity. So I can't affect the diversity at my workplace, but we can all improve our inclusion. So here are a couple of quick things that you can do at your workplace to improve inclusion as the higher ups continue to increase the diversity. Number one, in the words of the great philosopher Beyonce, say my name. It turns out that our colleagues who have foreign sounding or difficult sounding names report with very high frequency that people either don't call them by name, shorten their name, or give them an Anglo nickname, whether they want it or not. Medical friends, let me tell you, if we can learn to say things like endoplasmic reticulum and pyruvate dehydrogenase and endoscopic retrograde cholangiopancreatography, you can learn how to say Sukfirdantha. It's not that hard. So taking that step, taking that inclusion and saying somebody's name as it is, not what you expect them to be or what makes it easier for you, it makes such a difference. So taking the time to say the name is important. Read any of the Dale Carnegie literature, how to make friends and influence people, and it shows the importance of the name. Now, in addition to saying their name, whatever your culture is in the workroom, if it's to call each other by their first names, that's great, that's fine. When you are in front of a patient or in a professional setting where they are being introduced, use their academic and medical title. I cannot tell you, I couldn't even begin to count how many times I have been called nurse. I will have done an entire workup on a patient, pelvic exam, disimpaction, 50 procedures, it doesn't matter. And at the end of it, they say, "You're such a nice nurse. Am I going to get to see a doctor?" And then I had the added perspective of one of my Brown colleagues who heard me talking about that and said, "At least you get nurse. I get housekeeping." So the importance of saying someone's name, and then when they're in any type of professional situation, introduction at a medical conference, or in front of a patient, please use their academic title. Please call them Dr. Dantha, because while people might mistake you for a doctor, it doesn't happen to the rest of us very often. So the other thing you can do, now they've shown studies that workplace diversity has to be above 20 or 30% for people to even feel comfortable speaking up. So what you're going to find is even though you might have some diversity, your colleagues may not be as comfortable speaking up, especially if they are often silenced, interrupted, have their ideas taken from them, or don't get taken seriously. So you can hear what your colleagues are saying and make sure that you amplify what they said. Dr. Dantha, that was an excellent contribution and comment that you just made. Thank you so much for saying that. What I like about this is that you're not stealing it, you're not mansplaining it, you are giving them the credit and amplifying it. And lastly, bring people on as not just mentors who you guide, but also sponsor, and that's somebody that you advocate for. So let's say diversity and inclusion are huge, huge topics, and it can feel very weighty. How do we change the entire world? So just a quick recap of the few things that you can do, that you're empowered to do, that you can accomplish today. Audit yourself, expose yourself, ask questions, and don't assume you're speaking the same cultural context and vernacular. And when it comes to the workplace, say your colleague's name as they would prefer to say it. Call them by their professional titles in any instance where that's going to be important. And when they are making a contribution, acknowledge and amplify. And lastly, mentor and sponsor people, because the more people we bring up, the better the ideas that we can have, the more inclusion, and the less disparity we're going to start seeing in our patient studies in the future. And that makes me so excited. So I'll be back next week. We're going to have a panel and we're going to dive deep, get a little uncomfortable, and talk about the topics of diversity and inclusion. So I would love to see you there next week. Bring your thoughts, bring your ideas, bring your questions. And I look forward to seeing you next week at the Diversity and Inclusion panel. Enjoy the rest of this amazing conference. You're going to continue to get awesome content.